Hello everyone and welcome to Breast Cancer Network Australia's live webinar, which is titled Just Diagnose, What's Next? I'm Danielle Spence and I'm the Director of Advocacy and Policy at Breast Cancer Network Australia, and I'm really pleased to have some experts here with us tonight. We have breast surgeon Miss Carolyn Baker, we have breast care nurse Catherine Wallace, and we also have Renee Garney, who is a breast cancer survivor. And we are all here to spend the next 45 minutes with you and to really talk about how do you get through those early days when you're first diagnosed. It can be such a minefield, such a confusing time with so much information available through the website and through your people that you meet, as well as all of the health professionals that you're going to come in contact with. And so this webinar is really looking at what can you do in those first few days, how do you get through things, what is the information that's really important to know, what are some of the questions that you might like to talk to your treating team about. And we'll have an opportunity as we go through the webinar to ask questions, but we just remind you that we can't answer specific questions related to your own treatment, so just broad general questions might be something that we're talking about or something that's on the screen that you want to ask a bit more about or even comment on, and we look forward to receiving your questions tonight. So I'm going to head over now to Miss Carolyn Baker, who is Head of Breast Surgery at St Vincent's Hospital here in Melbourne and Chief Surgeon at St Vincent's Breast Screen. And we're really very lucky to have you here tonight, Carolyn. So let's get started and get talking about what is breast cancer.
So thank you very much for asking me to be involved this evening, Danielle. It's a great pleasure. So breast cancer is the most commonly diagnosed cancer in Australia, and you can see here from this lovely slide showing the field of women and the exponential growth in both the participants in the field of women and the number of women diagnosed, so that this year we could expect over 18,000 women to receive a diagnosis of breast cancer and approximately 150 men to also receive that diagnosis. So of course that many women being diagnosed means that their friends and their family and their work colleagues are exposed to breast cancer and need to have an idea of how to support them and to deal with them as they are moving through this somewhat terrifying journey potentially. So that's what we're here for tonight, to work to. So I think the first message to get across is that breast cancer is not the same. Each woman's journey is different, and one of the things that frequently happens is you receive your diagnosis and there's like an avalanche of people who are offering their stories to you to say, oh, this is what happened to my mother or my neighbour, and you've got to do this and you've got to go there, and this is really important that you follow this pathway because they're alive and they're well. But actually you need to be strong enough to say, my cancer is my cancer, and they are all different, and it's really important that you get a customised approach to your cancer management. And in this day and age, everyone should have an individualised care plan. So I have to say that I think the key to getting a clear plan is to understand the pathology of your cancer, because that is the thing that sets the tone. So the pathology is what your cancer looks like under the microscope, and it's made up of various components. So the grade is how biologically active the cancer it is. The size is obviously how big it is under the microscope. The receptors are specific features of the cancer that tell us how it's going to react both in your body and also to the treatments that we offer it. And the lymph nodes, or the lymph glands, are a marker of risk of the cancer spreading around the body. So whether or not they're involved is also very important from a prognostic perspective. So when we take all of those factors into account, plus the age of the lady when she's diagnosed, her general fitness and her breast size, that will allow her treating team to work out what is the best mode of care for her. And I have to say that breast cancer treatment is not just one field. It's multiple modalities are involved, and everyone will have at least more than one component of their treatment. Now tonight we're talking predominantly about early breast cancer. So I get asked that a lot. Is it early, doctor? Is it early? So early just is a combination of how big is the cancer and whether or not it's in the lymph nodes. Now it doesn't matter if the cancer is in the lymph nodes. we would prefer that it weren't, but it is still considered early breast cancer if it's just confined to the breast and the nodes. And in this situation, we're always aiming for cure. And aiming for cure means that we're aiming for survival. So one of the great things that's happened in Australia over the last 30 years is that our 5-year survival rates have grown from a low of 72% in the early 1980s to our current figure, which is now sitting at over 90% of women are alive and well with no breast cancer at 5 years. So that's a wonderful thing to celebrate. And I remind my patients when they're diagnosed that there are so many worse cancers that they could achieve that would not have the survival outcomes that breast cancer does. And we need to keep coming back to that as such an important factor in their care. So one of the first decisions that you need to make with your GP in hand is decide, where should I be treated? So you might think that's easy enough, but actually it's not. If you live in a metropolitan city, then you're going to have a lot of services on your doorstep. But if you live in the country, or you live hours and hours from the nearest large cancer service, then that is a really big consideration, because treatment is not necessarily just going to be over and done within 5 minutes. You are going to potentially need to commit to stay in the area where you're going to be treated, and that might be for weeks or even months. So the logistics of care needs to be very carefully assessed from the beginning. The next thing you need to work out is whether you want to be in the public system or the private system. Now, we are really lucky in Australia. We have excellent public health care, and people will not suffer by being treated through the public system. We can achieve the same operations, the same chemotherapy agents, the same drugs in public or in private. The difference is potentially the timeline that you can achieve your care in. Now, this is something I grapple with regularly with my newly diagnosed patients. Breast cancer is not an emergency medically. Psychologically, personally, yes, you really want to get on and get things sorted quickly. But actually, from a medical perspective, the cancer is not going to spread around your system 1 week after you're diagnosed. So don't be scared about a little wait before you get seen in a public hospital system. Things are not going to get out of hand. Now, one of the other important considerations about where you're going to be looked after is the co-localisation of many different services. And in the larger cancer centres and the larger public hospitals, you'll have reconstruction services, you'll have genetic testing, you'll have fertility services that are available for your access. And to have everything housed under one roof and to be integrated and coordinated takes one of those dreadful pressures away from you. What do I do? Where do I go? If someone can guide you through that, and the breast care nurse is very valuable in that situation, then that makes one stress being able to be relieved for you. The other thing to think about in your treatments is also the cost of how much things are going to add up to. Now, certainly for our patients who need chemotherapy, there may well be a considerable period of time off work, and there needs to be a careful consideration of the impact of your treatment costs and your inability to work on what you can access. Team care is the flag bearer of breast cancer care. And we've led the way, I think, in breast cancer care with a multidisciplinary team. And I'm proud to work in a couple where we all offer supportive, integrated care. And actually, it's been shown scientifically that multidisciplinary care will enhance your survival. So go looking for a team to look after you. At your first visit, when you come to and you're newly diagnosed, you'll meet at least 1 or 2 members of that team, myself, the surgeon, and hopefully a breast care nurse. If there's not one particularly evident, you should make sure that you ask to see if there's a breast care nurse available to see you. You should try and Focus the information you obtain in your first visit to the things that are immediately relevant in your time frame. So don't get caught up with the nuances of your anti-hormone therapy, which might not start for 9 months. Focus on the tests that are happening at the beginning, the outcome of those tests, how long it's going to take you to get from point A to point B, and the things that you might experience in the very beginning. Try and make sure that you get clear understanding of what's happening to you, because it's your body and your life. And if you don't understand something, ask again, ask a different way, ask for it to be written down, get shown pictures. And if you still don't feel like you understand even a little bit what's happening, ask for another opinion. It's perfectly valid. Any doctor worth their salt would not be insulted. Ask your GP to help you, and make sure you take all the information that you have at your fingertips with you to the next doctor. Otherwise, they can't offer you a valid second opinion. There's no problem with that, though. So your first appointment, I always think arrive early. Time stress, there's nothing worse. So take that off the table. Plan how to get there. Make sure you know about car parking. Take a pair of listening ears with you, a supportive person, and don't take your children, because, as we know, children get in the way when you're a mother. They're always doing something. They're the focus of everything that happens, and so leave them with someone else. Take your x-rays, not just the reports, the actual films. Write things down, ask lots of questions, ask for written information, ask for websites, ask for the My Journey kit, because the BCNA provides that for everyone who's newly diagnosed, and then try and prioritise what's important for you. Don't come into your first appointment with a lot of preconceptions. Don't go be a Dr. Google fanatic, because, as I said, breast cancer care is individual, and your cancer and your treatment is going to be about you, not what's on the internet. And an important part of that is you can go to some internet sites, but use the trusted ones that will be recommended: BCNA, Cancer Council, Cancer Australia. Now, the treatment and what's right for you is quite a complicated decision process, and you should be consulted all the way through and understand what the implications are. The important things that you want to know are how likely is the cancer to come back. And I may not be able to answer that for you right at the beginning, because I need to get as much information as possible to make that a valid recommendation. The pathology, as I've explained, is the key to everything, so I think it's a good idea to have a copy of your pathology, a written copy, and have that with you as your reference point. And the other things that are going to be included in what's important for you are what else is wrong with your health, because you bring that to your cancer diagnosis. It's the same as you bring all the other things that have happened in your life, so your family situation, your work situation, pre-existing psychological challenges all impact on how you get through your cancer treatment. So surgery can be either a lumpectomy or a mastectomy, and the decision about that is twofold predominantly. It's about how big the cancer is and how big your breast is. So that's a clear conversation with the surgeon, and you're allowed to express your own preference. And my job when I'm guiding you towards your decisions for your cancer is to make sure you understand the implications. I get a lot of ladies that come in and say, I want my breast off, I want it off now, in fact I want both breasts off. And if that is not going to enhance your survival, and in most situations it won't, then it's my job to make sure you understand that you're not going to choose more surgery simply because you're scared. Now, the lymph node surgery has come a long way. When I started out as a surgeon many long centuries ago, we did axillary nodes clearance on everyone, so taking all the lymph nodes out in the armpit. Thankfully, in 1999, we started doing sentinel node biopsy, which is a selective sampling of the lymph nodes, And this allows most people to keep their lymph nodes, but allows me as a surgeon to have the prognostic information of whether the nodes are involved or not without you getting the complications of all the nodes being removed, such as lymphedema. Now, if unfortunately it looks like you need to have a mastectomy, in this day and age, you should be offered the opportunity to explore an immediate breast reconstruction. Now, the logistics of achieving that can be challenging if you don't live in a metropolitan centre. And certainly some young people will choose to travel and find someone who can look after them so that they never have to be flat. So it's something to ask about. Occasionally, there are medical challenges to having an immediate reconstruction, such as in a bad cancer like an inflammatory cancer. But that needs to be spelled out for you if you're not having breast reconstruction offered up front. There are two basic styles of breast reconstruction. The first is using your own tissue, which is what we call autologous. And I always say the silver lining is the tummy tuck. If you can get that out of your breast reconstruction journey, that's a good thing. And you also get to make a breast of the size you would like it to be rather than the size you've been given, and can get some match-up surgery on the other side. Now, all of this is covered under Medicare, so you can achieve reconstruction surgery in a public hospital. The other form of reconstruction is using an implant or expander. They're silicone-based, and that gives very good reconstruction outcomes for ladies who don't have enough of their own tissue to make a new breast. People can have new nipples made as well, and as I mentioned, you can have the other side matched up to create your new breast. The reconstruction process is complex. It does potentially make your surgery longer and more fraught with complication. There are a lot of things that your surgeon considers in terms of what your options would be, and it takes a lot of talking. There's a good decision aid for you when you're thinking about the reconstruction process called Recondo, and you can see the website listing there. And I'd encourage all people facing a mastectomy to look at that, and also to speak to their breast care nurse about what it's like to not have a reconstruction and see a bra and a prosthesis. Other treatments that we would be looking at using in your therapy include radiotherapy. So that's like glorified sunbed treatment. That's what I say to my patients. You lie on a bed and you get zapped. It doesn't hurt. Most radiotherapy is short course now, which is over and done within 3 weeks. Some patients still need longer course radiotherapy, which is up to 6 weeks, 5 days a week to the breast, sometimes to above the collarbone, and occasionally to the armpit or the breastbone. You can work through radiotherapy, you can drive yourself through to radiotherapy. You are not radioactive, so that's a good thing too. Now, some patients also need chemotherapy. So chemotherapy is systemic treatment to stop the cancer coming back. How do we know that you need it? Again, it is based on your pathology, so what the cancer looks like. So there's a few cancers that we know have a higher risk of coming back. So the triple negative, which is the ER, PR, HER2 negative cancer, and the HER2 positive cancer are two groups that we've identified now that have a high risk of recurrence and where chemotherapy would be routinely recommended. Also, if the cancer is in the nodes, that's a marker of risk of systemic spread. So most people with cancer in their lymph nodes will get chemotherapy, as would most younger patients. So the thing with chemo is, yes, it has a bad rep for causing side effects and for your hair falling out, but there are a lot of newer developments in supportive care and also in wearing a cold cap to prevent the loss of hair. So these things should be readily accessible in modern cancer centres.
Carolyn, can I ask you, chemotherapy, we've talked about this as a treatment that might follow surgery. Is there any times where chemotherapy might be given earlier?
So there is a growing trend of what we call neoadjuvant chemotherapy. So adjuvant when it comes after surgery, neoadjuvant when it comes before surgery. And in particular, we use this in patients who have big cancers. We would like to try and shrink it so that maybe they won't need a mastectomy. When they have particularly chemosensitive cancers, so the triple negative, the HER2 positive cancers, where we know that getting the chemotherapy in early may have an impact on their long-term survival. So we also, when you're having chemo, you can watch the cancer shrink while you're going through it, and it's actually quite a validating experience to say, I'm having chemo, but gosh, that cancer's going away. So you know that it's going to be working not only in your breast like that, but also in the rest of your system. So more and more patients are being offered neoadjuvant chemo, and sometimes even neoadjuvant endocrine therapy, anti-hormone tablets for their cancers. So it's a watch this space for that.
Okay, thank you.
And the last sort of treatment I was going to talk about just briefly is what are the newer treatments, the targeted treatments. So again, coming back to the pathology, those features of the cancer that we've identified that tell us how it behaves can also be a target for our anti-cancer therapy. So for instance, a drug called trastuzumab targets the HER2 marker on the breast cancer, and that has had an amazing impact on an otherwise poor prognosis cancer in terms of allowing people to live long and happy lives. There are also a number of drugs that target the hormone receptors on the cancer. So the one that's been around forever is tamoxifen, but there's been a lot of newer developments as well. And people can be on those for 5, sometimes up to 10 years in different combinations and in sequence. And your oncologist, your medical cancer doctor, will be the important person that helps determine what those treatments are in consultation with you. Mm-hmm. So I think that's my spiel. It's the beginning of how we start, and I think we're moving on now to where do we go next?
Yeah, and we're going to hand over to our breast care nurse, to Catherine, and then Catherine will really talk about how do you navigate through all of this complexity. So there's a lot of information there, lots of specialists that you might be seeing, and it's really important to, I guess, have a constant, someone that can be a key contact as well. And so Catherine's going to talk to us about how the breast care nurse can fill that role. And then we, as I said, please send through any questions and we'll have a chance to come together at the end of Catherine's talk.
Thank you, Danielle. And again, it's a real privilege to be able to present tonight and help all of you women out there and any men that may have, are in this position of having an early diagnosis. I think it's really important to say that breast cancer affects the majority of people that are affected by breast cancer are well, healthy people. So this comes as an unexpected shock. So often at that first visit, as Carolyn has said, there's a lot of information. It is important to have an extra pair of ears there to perhaps interpret some of what's being told at a time where, most people are in a state of shock. And I guess that's where the role of the breast care nurse can also be not only an advocate, but mediate between the medical team and the person and their family, their carers. So I guess navigating, coordinating some of the information so that it's taken on board at specific times, and I guess it is important to know that it's not a one-size-fits-all. Everybody is different. Everybody will respond to their diagnosis differently. So it's really important as a breast care nurse to really listen to where that person is at that stage, not to overload them with too much extra information, but rather to listen, to perhaps reinforce some of the information, whether it's been written literature or at their first consultation with their surgeon, information that can be understood. Now that may be, particularly for people that may have English as a second language or different cultures. It's about individualising that information that is going to be specifically helpful for that person. yes, it's very much around physical support, but also the psychosocial support. We're trying to navigate people that are, through a traumatic experience, and I think you can never underestimate the impact that a cancer diagnosis may have on somebody. I think that it can be watered down. Every person, every second person you speak to has had cancer. It's not helpful for that person to know that when they're going through it. So it is important initially, I guess, to take time for the dust to settle. As Carolyn said before, nothing has to be decided upon in the next day. And I think more importantly, it's to minimise that amount of information that you can handle at that given time, and making it relevant to you. One of the more difficult things is to hear everyone else's opinion about what you should be doing and how you should be responding. Josephine Bloggs down the road might be a completely different situation. So it really is important to keep it relevant to yourself, to not Dr. Google, not to speak to everybody, not to take everyone else's well-meaning advice on board, because what might be a perfect scenario for one person is not necessarily going to be your story. So I think self-preservation, self-care is important in those first few days, to let the information that you've been given sink in, accessing it might be the resources through the Breast Cancer Network of Australia. You've got your helplines through the cancer councils, and just trying to take each piece of information just piece by piece, keeping it relevant, whether that's focusing on the surgery that's been recommended, or whether that's talking about other treatment choices.
Often a good thing to do is to turn your phone off. You get overwhelmed by people wanting to ring and offer support, but sometimes it's too much. So getting your partner to take the calls, to look after your phone, so then you can answer things in your own time. You don't have to send the same text 25 times. That's a good thing. There's also, I don't know if you've come across this good app called Gather My Crew, which helps the people who want to support you to do something practical. You don't need 25 casseroles, but you might need someone to pick your child up from school because you're having a CT scan. So that's a useful thing to help.
Yeah, I agree. And I think, when I'm particularly talking to young mums, the 3 C's, it's the childcare, the cleaning and the cooking. It's not about the cancer and the chemotherapy, the other C's. And encouraging women to sort of accept help, because it actually helps others as well as yourself. So you've got sort of a double-barreled benefit, because how many of us know women, I'll be fine, everything's fine, I'll just, soldier on. And sometimes I'll say to someone, that one of the greatest gifts you can give your friends and family is to allow them to help you at this time.
Absolutely. Yeah.
Because sometimes people just don't know what to say. And if they do say something, sometimes it's not necessarily helpful. So if they can do something, it's a win-win for both sides. And I always sort of say to people, if your friend was going through this, you would want to help. If they kept saying, I'm fine, I don't need anything, and they often say, you're right there, that's something that is good practical advice.
And I think sometimes you don't always have all the information, and people are really keen, what treatment are you going to be having, and you don't always have that at the first appointment that you meet your specialist. So that sometimes can take some time, it might mean more tests. So actually being able to say, we're still working that out and feel safe about that is also really important.
Absolutely, yes. And I think, again, gathering those close to you who you feel are going to be your greatest supports is terrific. And sometimes that can be a bit of a shock for people. You might find that those that you thought might be perhaps your greatest supports are nowhere to be found. Sometimes it's those people that come out of the woodwork that you might least expect. So it is, and in talking about these sort of things at the beginning, it really helps people think about perhaps those aspects that they may not have considered. So it's a bit of a forewarning. Again, navigating treatment options. Public versus private. I work in the public system and the private, and some people think because you've got private health cover, all the costs are going to be covered, and that's not always the way it works. I think it is important to raise those issues with women, to talk about the cost of treatment, and reassure them that we have a very good public system in this country, and no one is going to be waiting any length of time where they're going to be their care or outcomes are going to be compromised.
So can we talk about that? And people might be wondering, if they've gone and seen their GP, they've got a diagnosis, and they're being referred to perhaps a public hospital, what is an acceptable waiting time? What do you think, Carolyn, to get that first appointment?
1 to 2 weeks. Mm-hmm. Most public hospitals will make an effort to say that if there is someone who's either diagnosed cancer or likely to have cancer on imaging or the GP's clinical assessment, that they'll get them in quickly.
Yeah.
I suppose the challenge can be you can get in, but then there's usually only one clinic a week, so each step takes that little bit longer, and you just have to grit your teeth and know that your team will be trying to look after you to the best that you can, and they'll try and offer as integrated care as possible.
Yeah, okay, that's great.
Yeah, I think above all is, for people to understand that we are working in multidisciplinary teams, public or private. There's going to be a group of specialists who are going to be basically looking after you. And, there's a place for private and there's a place for public. And I think as long as people are aware of their options and aware of the costs and aware of things like waiting times, just to allay some of those preconceived ideas and myths and misconceptions that are out there.
And so what if you're worried that you're not being treated by a multidisciplinary team or a team approach? How do you actually, when you're first meeting a surgeon and perhaps you're in private, can you ask the question about whether they're in a team?
You can ask anything. And you would, hopefully your GP, who will have known you for longer than the surgeon has, will take your care on board and know that you want to be treated in a good setting. So trust your GP. You can also obviously Google the person you're being sent to and Google the service that you're being sent to, because a decent service will have a lot of information on the internet about what they offer. Okay, you can't. It's quite challenging at the beginning to feel that you can impact where your care is going to happen, but take a breath, and you can.
I think, the knee-jerk reaction can be a little, well, it really doesn't matter how much it's going to cost me. I just want this done tomorrow. And I think some of that is about reassuring and providing, that information to let's just take it step by step. There's no need to do anything tomorrow.
So I'm just going to ask a question, and Carolyn or Catherine might like to answer. So Sue's saying, would it be possible for GPs to be able to give women an information pamphlet when they're first diagnosed through the GP, when they're waiting for that specialist appointment? And Sue describes this as a really dark time, and it's hard to know or have any information when you're really waiting for that immediate sort of first appointment. So she's saying this is a really real scenario and it happens. What would you recommend for someone when they're leaving that GP and they really feel that I've got no information, where do I go?
Most GPs should be able to access downloadable information off the reputable websites. There's a plethora of breast cancer information, and we're extremely lucky for what our patients have available. The BCNA have information that is readily accessible. You don't have to be a health professional to actually access the My Journey kit. You can register and do that online and have it sent to you. There is plenty of information. It's just a matter of getting a little bit of guidance. So say to your GP, I've got to wait 2 weeks. Can you help me? And, GPs are there to help you as well. And in fact, GPs become a more important part of your care the longer that you progress through your treatment, because sometimes people end up in little tunnels and there's not enough talking between people. The GP should be the one also helping with the breast care nurse to make sure that everything gets looked at.
And perhaps if you're waiting those 2 weeks, you could make another appointment with your GP. So don't, rule your GP out as another person to go to if you're waiting on that first appointment.
Yeah, and I think another important point is to, make sure that you've got a GP that you're comfortable with. And if you're not, it's okay to change GPs. I mean, sometimes it's difficult to shop around. Usually the most popular GPs are the ones that are never available for a few months. But I think that's important to know that, you've got a regular GP who you can continue to visit throughout your treatment phase. Keep them in the loop as well, because they're going to be part of your treating team at the end as well. They're going to be looking after you.
And another resource is to ring the helpline that the cancer councils in each of the states, staffed by volunteers who are, it doesn't matter if you don't have a health professional looking after you yet, they'll still be able to talk to you and give you guidance and provide you information. So
absolutely.
Yeah. And I think it's catering for some, people who want lots of information in the beginning versus those that really don't want much at all. And I think that's, recognising that that's okay as well. And some of these treatment options that we're looking at, it can be completely overwhelming. It's like a tsunami of decision making when you're shocked and you're frightened or you're feeling anxious. And it is important for younger women to have those conversations around fertility. Knowing that sometimes these treatments can put women into a state of early menopause. These are the discussions, these are the things that women do need to know. Genetics, there's a lot of misconceptions again around family history, the relevance of genetics. Women are often surprised when I say most people diagnosed with breast cancer don't have a genetic predisposition. Most people, as I said before, are well, healthy people with perhaps no family history. But for those women who may feel that that's an issue, I think, again, offering them that or having that conversation with them.
There's been a lot of advances in genetic testing, and we're very lucky with our genetic services now that in the time of appropriate clinical need, you can actually get rapid genetic testing in a couple of weeks for those patients in whom a positive test result would make a difference to their treatment. And the cost of genetic testing, even for those who don't meet the Medicare criteria for funded testing, has now come down to about $450 for a panel test which pulls out the 5 high-risk single-gene mutations. So it's a very important discussion to have, but actually most people are not going to carry Angelina Jolie mutation.
Yeah. Along with the navigating, the coordinating, trying to provide practical assistance and support not only to the person but their family as well, is understanding the emotional impact of breast cancer. The grief and losses are multiple. It might be loss of income, it may be related to body image, it may be, loss of hair, loss of breast. Some women say, all my female bits are being assaulted. I feel like I'm losing my hair, my breasts are scarred, or I've lost my breast. I had a woman yesterday say, I know it must sound vain, but I'm actually frightened to lose my breast. And just, reassuring people that this is not about vanity at all. This is about a part of your body. This is about part of your femininity, your womanhood, your sexuality. And, it impacts on relationships. And I think it's a really important thing to include the partner in these discussions. Don't just isolate the partner, whether that be a female, male partner or whatever. It's important to include them in part of this discussion that can sometimes be missed. Again, physical impacts, the side effects from treatment. So, again, focusing just on the here and now. If they're having surgery, how long they may be in hospital, what might they expect? Will there be drain tubes? And these are things that the surgeons have already discussed, I'm sure, but it's really just, again, repeating it, because how often I hear women say, I was never told that. And you know that they would have probably been told in the initial discussion.
But reinforcing.
It is.
Right. So we've got another question from Karen, and she's just saying, listening to the role of the breast care nurse, is it possible that you can find out who your breast care nurse might be and connect with them before that first appointment with your surgeon? Is that possible in our public systems or our private systems?
Look, it is. Most women or men will have the referral for the breast care nurse generally does follow that surgical pathway. Unfortunately, sometimes people who go for the neoadjuvant treatments and then may come through the oncology pathway may take a little while to have a contact with the breast care nurse. So I think it's really important for women to ask the question, and I think it's really important for clinicians to also inform those new patients that there is a breast care nurse available. So sometimes we do need to rely on the clinicians referring the women to us, but I would hope that in this day and age most surgeons and oncologists would be aware of the breast care nurse and where their role would be.
Realistically, for the breast care nurse to be able to make significant contribution, they need to know something about the patient and their cancer. So having a contact before actually any of that's been established is probably not particularly helpful. Yeah.
Which reinforces that importance of the communication between the team as well.
Yeah.
So we're just coming towards the end of our session, and we've still got to hear from Renee. So, Catherine, how do we talk to this slide? Breast cancer's just a part of you, not the whole you.
Look, I think it's a life-changing moment. Some people may say, I'm still the same person, but I think irrevocably, they're reassessing their lives, they may be reprioritising, and I think the important thing is just to support that person through that journey. And I just chose this little gem from Looning. How long will my life be? As long as a piece of string. Will my life have knots in it with loops and tangling? Oh yes, it will, and bits will twist and trip you up and fray. So long as it's continuous and goes from day to day, your life should be okay. And I guess that's what we're here for, is to say we're here to help you.
So Renee, tell us, you've gone through this experience, you're on the other side, so to speak.
Yes.
The word survivor, I'm not sure how that sits with you. Sometimes people...
I love that word.
That's good. So we'll call Renee a breast cancer survivor.
Yes.
And tell us any tips or anything that people can learn from your experience.
Listen,
Renee.
I'll just briefly go through a little bit of my journey. And again, a lot of people don't like that word, but I can't explain it any other way. So this is me, 36 years old. I was diagnosed with breast cancer. I had 2 young children, 3 years old and 7 months, and this is me on my first day of chemotherapy when I was just about to walk inside the hospital. And I look at this now, being almost 4.5 years on, and it sort of feels like I'm a completely different person. Even though I know that that's me, I still feel like, wow, it's just been a really, really, really interesting and not always negative journey along the way. So I had chemotherapy and Herceptin, and then following through that treatment option, I had a double mastectomy. Now, I went through with my surgeons and had many conversations with them about the different options that were available, so you can see that. Hopefully you can see the difference from one from the left to one from the right. As you were mentioning before, I did have that operation where you can have a little bit of a tummy tuck. So that was my silver lining for everything. But I really think through this process it's very important for people to remember to ask so many questions. It's a big decision, it's a big surgery, and you want to feel 100% confident in what you're going to have. Life goes on afterwards. I went through my chemotherapy, I had my surgery. There's just a few pictures of me and my family when my hair was growing back, when I didn't have a lot of eyebrows, and I was, enjoying wearing my scarves. So life did go on, and I think the most important thing that I wanted to get through to people tonight is things that I know now that I'd like to pass on is take a book to every session, write down all your questions, you will forget them. There is no way that once you're sitting in front of your surgeon that you'll remember all of them. Ask all the questions, it's your right to ask them, and don't feel embarrassed to do so. Trust your medical team 100%. If you don't trust in them, I would suggest maybe getting another opinion, because if something's not sitting right with you, then maybe there's a reason for that.
Yeah.
Don't Dr. Google, worst decision ever. Don't watch any YouTube videos. Don't watch anything like that. Just stick with the medical information. Say yes to help, as you were saying before. No one would be offering it if they didn't really want to offer it. So symptoms won't last forever. My hair grew back. I got a new hairstyle, and the pain went away. Exercise. Make sure you get out, get some fresh air, even though you might not feel like it, and join a support group. We've got some great support groups online and in person. So just stay strong, and you'll come out the other side.
Thanks, Renee. So we might go to our last slide, which is hopefully a shot of Breast Cancer Network Australia. So we're here to support any newly diagnosed woman or anyone who has breast cancer, or their family and supporters. And you can see our website, you can see our 1-800 number. We have our nurses on our helpline who might also be good people that you can talk to, and they can certainly connect you with local services, especially if you're not sure if there's a breast care nurse in your area. We can help connect you with someone. So I really just want to take the opportunity to thank everybody on the panel for coming along today. It's been great, and you know what we hear so much at Breast Cancer Network Australia is really, what do I really need to know when I'm first diagnosed? And that was why we ran this forum tonight. We have had some questions that we haven't had the time to get through, but we will reach out to anybody that sent a question in that we haven't been able to respond to tonight. So thank you to all of our panellists for your time and expertise, and for Renee for sharing your story. And please come and look for BCNA and any ways that we can support you. So thank you.
Thank you.
Thanks.